So I'm going to present to you today kind of a very unconventional topic. And for those of you who haven't actually sat in on any of my rounds in the past, I tend to put a focus on mindfulness practice. And it's essentially an Eastern approach to meditation that we've somehow constructed in the West to kind of clear the clutter in our brains. And it's a great practice for those of you who have learned about it and tried it and who practice it continuously or not. But it's a new thing, and it's being covered in a lot of curriculum, including medical teachings at the moment in medical schools. So I try to bring that topic into my rounds to highlight our own kind of givings to the practice, but also to our shortcomings in medicine as well. So it's not your typical medicine rounds that you would expect. It's a little bit more simplified and a little bit more personally based, and hopefully you all get something personal out of this rounds. And so we're going to talk about the limitations of the medical model, and we're going to use a case study from our own emergency department. This case study surrounds a patient, AS, and he was a 63-year-old male who presented to the emergency department at our hospital with nonspecific abdominal pain, weight loss, and anorexia for about 2 weeks. He was a handover patient and just simply awaiting CT abdo-pelvis. It's pretty obvious just from the presentation that the diagnosis is likely to be quite suspicious. Verbal report of the CT came back, and it, of course, showed a mass in the head of the pancreas with some distension of the common bile duct, the gallbladder, and mild intrahepatic duct dilatation. Obviously suspicious for malignancy. So the next step we're all familiar with is accepting and having to go into the room to break some bad news. But I want you to be able to ask yourself a couple of things when thinking about having to break some bad news. The first thing is how have we been taught to translate a diagnosis with a poor prognosis? What has been your experience witnessing mentors and colleagues approaching the same situation? And how do you presently approach the breaking of bad news? And is there any area for improvement? So if we discover, so what we discover if we're actually honest with ourselves is that the first limitation of the medical model is how language is used and conveyed. Language is pretty powerful, and I often don't think we give it enough credit. So let's look at it, instead of breaking bad news, let's look at it as breaking unexpected news. Let's practice addressing the breaking of news as unexpected and avoid any negatively biased or charged terms like bad or unlucky But the issue here is, for this method to actually work, we as the physician must practice changing our personal attitudes on how we view the disease. We have to believe that this news is not bad, that it's actually indeed unexpected, but there's something more to the language than just simply being bad. How often do we bring into the room with us the doom of the diagnosis, and how does that affect patients' outcomes? And then finally, how does our language influence and construct future negative attitudes and mindsets for both the patient and family when they're hoping to heal? And remember, this is just simply us walking into the room and how we construct our approach to walking to that room. We just have to think about it in a more positive way. That's just, the physician, we haven't actually entered the room yet, and already so much has been uncovered. So breaking unexpected news requires more than just changing our attitudes around disease and how we use language to convey a diagnosis, but it also requires a physician to be physically present with the patient, which is another limitation of the medical model. Our emergency department traditionally is constructed for rapid assessments and discharges, certainly not always providing a platform for supportive consultation. Unfortunately, as a specialty, we have resigned ourselves to the negative motto, moving the meat. And it is this teaching with these attitudes in such limited and constrained work environments that prevent many of us from actually being present. So what does it mean to actually be present? Well, the tricky part is we've learned these skills as children. In fact, I think sometimes children have better communication skills and being present than we do as adults, particularly given the new social milieu that we're in. The very fact that I'm talking to you about this on Zoom is, again, reinforcing this idea that our communication skills are not being practiced as much as they should. And I question you to question yourselves is how much more can we improve our being present with patients. So obviously we sit down next to the patient with good eye contact. Sometimes we don't do that very often. Try not to rush the explanation of a diagnosis and allow time for both the patient and family to openly explore the diagnosis in their own way, which takes a lot of time and usually takes a few visits during the same consultation. And consistently reestablish positively charged language, not just for yourself, but for the patient and the family members as well. Furthermore, and probably the most important one, is to listen closely to what verbal cues come up during the supportive consultation. This will help you establish a management plan that reaches far beyond the limits of what the medical model can offer and what we usually offer. So what issues did come up when unexpected news was delivered to this patient and his wife with a supportive, positive approach? Well, the first issue that presented itself was the obvious limitation of the medical model in management. Given the diagnosis of a painless pancreatic tumor, the only option for the patient on leaving the ED was an outpatient referral to general surgery in review of potential surgical considerations, and that was it. And this, of course, is our physician-directed management plan. What other issues were revealed? Well, clearly there was an ignorance around diet. The patient's wife, in recognizing her husband's anorexia, had been encouraging him to eat eggs as his only food source to keep his protein up. There was revealed ignorance around their lifestyle. The patient had been attempting to continue his work duties while he was ill. So for the last 2 weeks, though he couldn't tolerate much food, he was still making sure he went to work. Ignorance around supportive networks. The patient stated, as we were elaborating on this safe consultation, he stated that it sounded like the physician was giving him a death sentence. This kind of highlights the inability for the patient to conceive of change, even if it's to his own benefit. It would have been easier for him to actually have accepted bad news. That's a whole nother talk. And of course, the wife revealed her previous battle with breast cancer during the safe consultation, which was now in remission, a topic that her and her husband had not previously explored in depth together because of taboos surrounding cancer. So what are the outcomes to breaking unexpected news in a safe place? Well, the subtle issues that we just spoke of, which would have otherwise not have been revealed, become disclosed within the safe space. Both the patient and wife are able to clearly ask for help on how to move forward. So now we go from a physician-directed management plan to a patient-directed management plan, just out of the interest from themselves. And with these initiatives of the patient and the wife, these subtle issues can then be translated into a working management plan, encouraging the participants, and this includes the physician, to look beyond the limited medical model for answers. So how do we look beyond the medical model to provide an alternative management plan? Well, as we discussed, the issues come up, and within those issues is essentially the management plan in itself. And we'll, for the sake of simplicity, we'll call it the 4 collaborators. Diet comes up, lifestyle comes up, an emphasis on supportive and positive relationships comes up. And part of the second collaborator, lifestyle, but also stands highly on its own, is the engagement with the natural world. So how can we take these 4 collaborators that came up in that supportive consultation directed by the patient and wife? How can we take these collaborators and rearrange them to create a management plan outside of the medical model? Well, let's look at diet first. And this is one of the hardest things to look at. So we'll tackle it first. So the physician offered a plant-based diet. The wife clearly stated that her husband was not a meat guy and that this approach was unlikely. Patient agreed, and he couldn't imagine a diet without meat, even though he had not eaten much other than eggs for the last 2 weeks. So already, just with the language, there's huge obstruction. Let's look at a little bit of evidence. So what does our Canadian food guide suggest about food in general, diet in general? Well, many of the well-studied healthy eating patterns include mostly plant-based foods. Plant-based foods, we mean by vegetables and fruits, whole grain foods, and plant-based protein foods. So you can get protein out of plants. Eating plant-based foods regularly can mean eating more fiber and less saturated fat. This can have a positive effect on health, including a lowered risk of cancer, heart disease, and of course, type 2 diabetes. So there's an ever-increasing amount of literature associated with high intake of meat, especially red meat, processed meat, with an increased risk of cancers, especially the colorectal cancers. One study was done in 2006, and some of you may have been familiar with it. It's called the China study. Dean Ornish, a respected American physician and founder of Preventive Medicine Research Institute, called the China study one of the most important books about nutrition ever written. Reading it may even save your life. It was a very large-scale study in China, and it linked Western chronic diseases to diets high in animal products. Really, the essential note out of it was that there was good evidence for the promotion of a plant-based diet as a means of preventing and maybe even reversing disease. Sure, there were a few weak points, but the overall take home with this was that this China study, put out in a large book, accessible to the public, played a valuable role in highlighting the chronically overlooked role of nutrition and medicine. Another study, a little bit more down our lines, was released in the International Journal of Epidemiology, and it was a UK-based study. And they found that people who ate red or processed meat 4 more times a week had a 20% higher risk of colorectal cancer than those who indulged less than twice a week. To break that down in terms of having 25 grams of processed meat, which is literally this equivalent to a slice of ham, colorectal cancer risk increased by 19%. And for red meat, serving 50 grams, equivalent to a thick slice of roast beef, that risk went up by 18%. So what about lifestyle changes? So the second collaborator. The physician recommended to the patient time off of work. The patient was extremely alarmed with the suggestion and said that he would actually go crazy if he were to sit around at home. This, of course, reveals how his personal identity has been shaped by his work placement. It's an identity defined by work performance, social expectation, and the interpreted value of income over self. Also, in terms of lifestyle changes, low impact exercises without distraction were encouraged by the physician. And what I mean by without distraction, I'm talking about doing an exercise to help clear the mind without any distraction. So no cell phones, no music, no walking in the park, talking of financial concerns, just simply doing something like walking in nature, clear-minded, practicing a yoga practice, Tai Chi maybe, or even meditation. The third collaborator, which was acknowledged and brought back as in terms of management plan for the patient, was a supportive and positive relationship. So the patient was encouraged to reestablish his relationship with his wife, both emotionally and physically, and allowing himself to be vulnerable in doing so. He was encouraged to reestablish relationships with other close family and friends at this time. And he was temporarily discouraged from engaging with relationships that foster negativity. So this is obviously difficult. I mean, how do we support positive relationships and put on hold the negative ones. But for us to learn how to heal in a different way, this has to be done in the short term. And then eventually, patient was told that he could re-engage if he could learn how to understand and forgive people in their negative presentations. And if you're able to forgive those negative presentations, then there is certainly some healing to be done through these other relationships. But for the time being, it was very clear that he needed to be around a lot of support and a lot of positivism. And then finally, the fourth collaborator is simply engaging with the natural world. Again, part of the second lifestyle theme, but in a little bit more depth. So the patient was encouraged to integrate with the outside world on a consistent daily basis. I mean, when you speak to patients, I mean, even look at ourselves, if we're honest with ourselves, how often do we actually get out of the house to walk through the woods? Again, yeah, part of the second lifestyle collaborator, but also stands alone as an important pillar to health and healing. Often in our culture in the West, there's emphasis placed on physical and material measurements to create a standard for quality of life. Again, for example, our work roles as defining our sense of being. And rarely do we consider one's own internal sense of well-being, of mental well-being. So nature easily reminds us of what this is and how to actually maintain it. So in summary, the medical model that we work in simply limits our and the patient's potential every time. Our behaviors as physicians and attitudes towards disease within this limited medical model confine how we collaborate on managing the disease. If we can change our attitudes, a paradigm shift can occur in the management of disease, where the reestablishment of health and balance can actually occur. And what we've learned through this discussion, hopefully, is that positively charged language can create safe space where real listening during the sharing of unexpected news occurs. When real listening occurs, then subtle issues, very subtle issues, reveal themselves on behalf of the patient's own initiative. It's these subtle issues, when recognized, that can become the platform for healing, as they are transformed into a management plan for addressing the very same issues that came up, the issues that the patient in their disease state has allowed to bring forward. This alternative management approach, which expands the limits of the medical model, can be characterized through the four collaborators used to guide the patient's healing process. Again, plant-based diet, lifestyle changes to redirect perceived social responsibilities to a personal responsibility, emphasize supportive and positive relationships to encourage healing, and engage with the natural world to realize our interdependent sense of well-being. And I'll leave you with a thought from a Buddhist monk, Thupten Jinpa. And he talks about what is the mechanisms for transformation from a Buddhist perspective. And he says for any change to occur, we have to go through the first stage, which is having the right view or outlook. That's kind of self-explanatory. The second stage is meditation, and let's expand that into creating a safe environment, whether it's a work environment, whether it's a consultation environment, a safe environment that allows us to become a little bit more realistic with our own personal needs, which then opens up the third stage of action. And that's it, you guys. I've left a couple distractors for you if you're into Netflix, about a few movies that kind of hint on similar themes as well. And I'm going to... If there's any questions, please. I guess I have to come off.
Jay, I'm going to ask a question. So first of all, thank you for this. I mean, I think it's great for us to take a moment to think about things perhaps a little differently than we often do on busy shifts. I guess my question is, how does one integrate the different approaches that are available out there into our sort of modern medical approach, because you've talked about a different model or the limitations of the current medical model. And yet that same medical model is one that has been taken up across the world. It's one that has responded quickly to the COVID outbreak in terms of developing a vaccine in 10 months, etc. So how do we, yet I'm not trying to say that I'm, that personally, I think there's so much that we should be doing to focus on prevention, on the mind-body relationship. But I know you've covered this, so I'm not asking you to repeat the talk again. But what do you think is the secret to incorporating perhaps alternative perspectives and still getting the core parts of the traditional Western medical model right? In other words, not throwing it all away.
Yeah, it's a great question. Yeah, I think transitions are important, but I don't feel that the medical model that we offer, as you can imagine, is sufficient enough. I think all the constructs that we have in society at this moment aren't sufficient enough, but there has to be a form of transition that has to occur from now moving forward. And I guess your question, if I'm understanding it correctly, is how do we do that gracefully? and what might it look like? And it's difficult to anticipate what's to happen. I mean, we all like to think that a vaccine will help us understand COVID and control this epidemic a little bit better, but that's just us trying to have control. I think we have to just give up control and allow the uncertainty to be there. But that's a personal journey. And I think a lot of these talks, I try to emphasize that we can really displace the message by focusing on the patient when really the learning has to do with ourselves. And if we can actually tweak that and understand it better, then the answers become clear. And what those answers are very, very subjective to each of us. And so I guess to answer your question is, if we can all adopt some form of gentle practice in our lives, taking a moment away from work and the busyness of the stressors that are ever present, and to find a new way to open up, then I think those things become pretty obvious and self-explanatory.